Here's your scenario. Let me know when you've had enough time to read it, and we'll begin. Okay, I'm ready. Given the location of the fracture, what nerve is at risk for being injured? That would be the radial nerve because of the way it wraps around the proximal humerus. Is there any role for regional anesthesia in this case? For surgeries involving the humerus, you can use either an interscalene or a supraclavicular block as your primary or post-op analgesic plan. What are the main advantages and disadvantages of using the interscalene block? A couple major benefits of the interscalene block are it's superficial in the neck, so your imaging looks very good on ultrasound. It's also away from the apex of the lung, so low likelihood of a pneumothorax. You reliably can hit the supraclavicular C3 to C4 innervation, which is sensory for the shoulder joint, as well as hitting the C5 and C6 nerve roots, which control the deltoid and allow for relaxation. The major disadvantages are you will get 100% knockout of the phrenic nerve on the same side you're doing the block, so patients will get the hemidiaphragmatic paresis, which will cause shortness of breath. Might not be ideal for patients with baseline shortness of breath. What are some advantages and disadvantages of the supraclavicular block? The supraclavicular block can also be used for upper extremity surgeries. It's also very superficial, so the imaging turns out really nicely where you can visualize the local anesthetic as well as the avoiding arterial injection. You are a little bit closer to the apex of the lungs, so there's a higher incidence of pneumothorax, however, lower likelihood of phrenic nerve involvement. What's the max dose for bupivacaine, and is local anesthetic systemic toxicity common here? Max dose is 3 mg per kg, and last is more common in intercostal, caudals, and epidurals.